Well, good afternoon, everyone. This is Mark Skidmore. I'm the director of the North Central Regional Center for Rural Development. Thanks for joining us on this webinar. Today we are, I'd like to introduce Scott Loveridge and Courtney Cuthbertson, who will be presenting some research on recognition and stigma in depression and anxiety. And this research comes out of a nationally representative study evaluating mental health literacy, and actually we looked at 4 components of mental health literacy: depression, anxiety, prescription drug misuse, and alcohol abuse. And so today Scott and Courtney will be talking about depression and anxiety, the results from that part of the study, and Rob Shupp will be giving a seminar on January 17th. So that's the second component. So these are 2 sort of connected webinars. All of this work was funded by a SAMHSA USDA collaboration called CAPE, Community Assessment and Education to Promote Behavioral Health Planning and Evaluation. And so it's a part of a larger program designed to help communities understand the challenges they may have, emerging challenges in behavioral health, and give them tools to address those challenges. So with that introduction, I'd like to pass it on to Courtney and Scott. Thank you so much for being here and doing the presentation. One other thing before I let them take over, you can see on your screen there's a chat section, and you can type in any questions or comments you may have, and we'll look at those along the way or at the end. We'll try to get to those. And also we're finalizing a research paper, so comments, suggestions, or thoughts are very much welcome and appreciated. So with that, I'll pass it on. Thanks again, Scott and Courtney.
Courtney, did you forget to unmute?
I'm here.
Okay. I thought you were going to do the next slide. Okay, I'll do it. I wanted to, Mark already mentioned that SAMHSA and USDA are helping with this, as are the 4 regional rural development centers, so wanted to thank them. Also wanted to point out that the paper Mark mentioned is a collaborative effort with several authors, some of whom are not presenting today. Mark Skidmore, Robert Shupp, Courtney, and Paula Miller from Ohio University, and Stefan Gitz from Pennsylvania State University. So with that, I think we'll just go to the outline, and Courtney, you can take it over.
All right, so today what we'll be sharing with you from the work we've been doing, we'll talk a little bit about how mental health issues have a geographic component. They're regional and even more localized than that. We'll talk about the role of recognition of mental health issues as well as stigma in terms of mental health recovery. We'll share with you the design of the survey as well as the results and some community responses that we have seen as we have been working on this project. So we know that mental health is an individual issue, but it's also a community and economic development one. Mental health does vary by place, and we have included here a map that comes from the CDC, where we've got county-level prevalence of frequent mental distress among U.S. adults, and this is for the time period of 2003 to 2009. And we can see that there's some regional variation. Thank you for working with the green arrow there, Scott. But we can see that in the Appalachian region, there's some there's higher prevalence of frequent mental distress. We can see there's some up in Maine as well, extending all the way through that Appalachian region into the south, a little bit in Oklahoma as well, and then some over in California, where we see that there's less frequent mental distress kind of in this north central region, in this part here, across the Dakotas, Minnesota, parts of Wisconsin, and extending down into Nebraska, parts of Kansas, and also parts of Iowa. We know that poor mental health creates different kinds of costs. One of those types of costs is direct, and that really refers to things like healthcare, access to healthcare, being able to see a mental health care professional. And poor mental health also creates indirect costs. So this might look like costs to employers because of time off of work, or needing to take off of work to go to those appointments. And in some recent research, we found, we have some colleagues who have found that poor mental health costs the United States as much as $53 billion annually. So when we're thinking about recognition, stigma, and mental health, thinking about the mental illness context, we know that mental illness is treatable. Past research has shown that people who don't recognize that they are experiencing a mental illness are unlikely to seek treatment, or that treatment might be delayed. Less than 50% of people experiencing a mental illness reach out to get treatment in any given year. Stigma also causes delays in treatment, or it can cause people not to seek treatment at all. When we're talking about stigma, what we're thinking of are negative perceptions around mental illness and people who experience mental illness, and those negative perceptions can influence whether someone seeks treatment because perhaps they don't want to be labeled, or in very small communities, they don't want their car to be seen at the place where people offer mental health services. They're afraid of what others might think of them. We know also that delaying treatment of mental health issues allows for the frequency and severity of episodes to progress, and can also impact the ability of individuals who face mental health issues to carry out their everyday kind of activities, going to school, going to work, and engaging in satisfying relationships. Scott?
Thanks, Courtney. That's a great introduction. And as Mark mentioned, we did 4 surveys related to these issues, and we're going to talk about 2 of those today. And to help put you into the kind of the framework or the frame of mind of thinking about the results, we're going to ask you to answer a couple of the questions that were on the survey, just to give you a sense of what the respondents went through when they were taking the survey. So if you could read that scenario about this person, and then if Rosa, you could move the "what is wrong with Michael" over on next to that. So I can't see the scenario anymore. So yeah, kind of shrink it down and make it so people can read the scenario. There you go. So take a second to read that and then answer the question, what is wrong with Michael? And you can answer as many as you like. And Rosa, probably don't broadcast it just yet. Okay, there we go. Okay, we've got 26 people on the line. About I'm seeing votes from about 10 or so. So we'll give you a little more time. Okay, I'm not seeing much more activity now, so we'll broadcast this one. So So it's a pretty good range in terms of what people thought was wrong. Then, Rosa, you can cover up the scenario now with poll number 2. Now we're going to ask you your level of agreement about Michael in terms of, do people with Michael's problem, can they get the help they need, or they can't get the help they need? And whether you strongly agree, neither agree nor disagree, strongly disagree. So. And on this one, you can only check one, so you have to make a decision. Okay, looks like we're pretty good there, so let's broadcast that one as well. So the first question had to do with, identification of the condition that this person, Michael, was suffering from. And the majority of you did indicate the anxiety disorder was the issue, and that was what it was designed to do, was to present some symptoms that are commonly associated with anxiety disorder. And then the second question that you answered had to do with one of our ways of measuring respondents' stigma toward individuals that are suffering from that condition. Now, the respondents, like you, were not told the name of the condition that we were trying to portray in the scenario. They were just given the scenario, and then would you agree or disagree with this one? And there was actually a number of statements that we asked about stigma, but given the time limits of the webinar today, we're not going to take you through all of those. We'll show you the results, but here we are just trying to get you into the mindset of the respondent, so you have a little better sense of the questions that we were analyzing later. So, Rosa, if you could remove those polls. So we did 2 national online surveys, and what you saw was an excerpt from the anxiety one. We had about 600 responses from that. We did another one on depression, where we had 2,500 responses. And the key activity was a response to the vignette. We had a bigger sample for depression because one of the things we wanted to do was to see whether the name of the person in the vignette would make a difference in terms of people's perception of the individual. So we had, we randomly did male and female. So the female was Michelle in the anxiety survey. And then in depression, we had a whole bunch of other names that are commonly associated with different ethnicities. And we didn't really find much in that, but we wound up with a bigger sample. So, but we'll talk about some of the results now. So, in terms of what is wrong with Michael, in this case, we'll just use, it was X. We say X in our report because we had all these different names associated with it. But in terms of what's wrong with the person, you were a little better than our national sample in terms of recognizing anxiety disorder as the issue we're trying to portray. So that's marked in red there. About 46% of the people answered that one, that option. A lot of people just said it was stress, which is similar to what the group here today said. And then a lot of people also mentioned depression, which is not what we were trying to portray in the vignette. If you go to depression, a much higher proportion of people were able to identify that correctly. But in both cases, the highest frequency was the issue we were trying to portray. We also saw people saying psychological emotional problems, stress, So nationally, people are sort of okay at identifying these things, but just imagine what it would be if you described flu symptoms. You know, how many people do you think would be able to correctly identify flu symptoms? I would guess it would be, 80 or 90% would get that right. So we have some distance to go, I think, is the main message that comes out of that. Okay, so then if we move on, we asked actually 12, so you answered one of the 12 stigma questions, and so we asked a variety of these, and the print is a little bit small, but so we asked it, you can't get the help they need, which is the one you answered. I would not vote for a politician who had this problem in the past. I would not employ a person who had this in the past. I would not vote for a politician who currently had this problem. I would not employ a person who currently had this problem. People like this are unpredictable. It's best to avoid people like this. This is not a real medical illness. This is a sign of personal weakness. Michael could snap out of it if he wanted to. If I had a problem like Michael's, I would not tell anyone. And then people like Michael are dangerous. So those are the 12 questions that the survey respondent answered. As you can see, where's my pointer here? So the green are basically people who are strongly disagreeing or disagreeing with the stigma. So these are people that are not in accepting this as something they would feel toward the sufferer of the condition. And then the yellow are more neutral, and then you've got the red and the pink are people that seem to express some stigma. And the good news is that for most of these, there is at least about half of the population that we sampled is not feeling any stigma toward the person. Gets a little worse on unpredictable. Let's see. But this is the one that we'll focus on later, is that this condition is a sign of personal weakness. If you think about some of these other ones, they're not really blaming the victim, but this one they're blaming the victim. And yes, it's a minority, about 20% have that form of stigma, but it turns out to be kind of an important indicator of stigma. So we'll think about that. Any questions about that? And this is anxiety, and then we'll show you another graph that's similar for depression. So before I move off of that, let me give you a minute to look at it. Okay, so this is the same thing now for depression. And again, you see a little more variety here in terms of the proportion of the sample that is disagreeing with stigma. Unpredictable gets a little bit worse there. More people in the neutral category, more people in the agree category. But still, a strong proportion of the population is expressing these stigma opinions about the sufferer. So, but identical questions, different population or different sample, but very similar structure to the questions. And we didn't show you the depression vignette, but it was very similar to the anxiety one, but different symptoms. Okay, so with that basic information in mind, we wanted to kind of say, well, what are some of the things that are associated with somebody's ability to recognize these conditions. So we did a logit regression on whether or not the respondent clicked the appropriate condition. Again, the two different surveys, so whether they clicked the anxiety on the anxiety vignette and whether they clicked depression on the depression vignette. So we had two logit equations going there. And then we had a whole bunch of control variables that are about the respondent. It's, their age, their income level, gender, things that are going on in their county of residence. And so the main findings out of that regression are that males are less likely to recognize either condition than females. So raise your hand if that's a surprise. No, not many people raising their hand about that one. I guess men are just less, unsurprisingly less in tune with these things. Oh, Brent raised his hand. Okay, good. One person is surprised by that. All right, good. That was less surprising to me than some of the other things I found. 18 to 34-year-olds and 55-plus people are less likely to recognize depression than middle-aged people. I was a little surprised that the older people were better at it than the middle-aged people, and it may be just a function of more experience going on there. And then also surprising was that people in the middle income range of 75 to 100,000 are less likely to recognize either condition than people in the base category. So the way that these work is you have to have a base category in this form of regression. So they're better at it. They're less good at recognizing these conditions than people that are making a little less money. So that was a little bit of surprise. And then even more interesting is we controlled for the rurality of the county based on the ERS rural-urban continuum codes. And so if people lived in one of the three most rural categories of county, we had a control variable for that. And respondents in rural counties are more likely to recognize both conditions than people who live in other types of counties. And that was pretty surprising to me, especially after controlling for all the other things that we had in the equation. And then we also found that, again, counterintuitive, counties that had higher levels of mental health provider access are also less likely to recognize either conditions than those from counties with low access. So we had data from the Robert Wood Johnson Foundation that provided what quartile the person's county was in terms of provider access, and somehow the people that with less provider access are less likely to are more likely to be able to recognize it. So perhaps there's a role for those providers to do more in education on these topics. So moving from that onto the stigma analysis, again, this is a regression approach, but now we have a bit more categories. Before it was 1, 0 when we were recognizing it, whether they recognize it or not. Now we've got, do they agree with stigma? Are they neutral about stigma? Or are they disagreeing with stigma? So are they pink or red? Are they yellow? Or are they green, if you go back to those two graphs I showed earlier? So we're using the base category of neither agree nor disagree. So our results will tell us, does somebody put themselves in more likely to put themselves in an agree category or more likely to put themselves into a disagree category, as opposed to neutral. And as I mentioned just now, we did combine agree, strongly agree, and strongly disagree and agree, so that we only had 3 categories to look across, because we're essentially measuring a similar thing between those two stronger categories. And then again, like we did with the earlier regression, we used respondent and county residence controls, but we used all 12 forms of stigma and both conditions. So we had 24 equations, each with 2 columns of results. And Mark only gave me 20 minutes or so, so we're not going to go through all of those. We're just going to talk about the strongest equation, which is a problem like Michael's is a sign of personal weakness. That provided the best fit of all 12 measures for both conditions. And, you know, very importantly in my mind, if the respondent had earlier correctly identified the condition, they were much less likely to express stigma toward it. So they're more likely to agree, less likely to agree with the stigma or more likely to disagree. In terms of age, 55 plus was less likely to agree to stigma on anxiety, and also less likely to agree on depression and more likely to disagree on depression. So the kind of a reversal on the 55 plus, as opposed to the other results. They're maybe less likely to be able to identify it, but more likely to not stigmatize it. And the other variables were there as controls, but less important in terms of their policy implications. So very strong results there, and kind of pointing toward the conclusions here that really it's recognition that is key to addressing mental health issues. If you educate people on how to recognize the condition, the issue of stigma may also decline, because the people that recognize it were less likely to be stigmatizing it. And so obviously if things are less stigmatized, people are more likely to seek treatment. But really you don't have to tell people don't stigmatize, you just have to tell them it's a medical condition and here's how you recognize it, essentially. So I think the conclusions are pretty powerful with that and provide direction in terms of going forward and how to work on these conditions. There are some results that are worth exploring further. Why is it that rural people can recognize these conditions more easily than people living elsewhere? And why is it that the status of mental health provider access does not seem to improve recognition? So there's some things to tease out more maybe in subsequent studies with different approaches than what we had with the national survey. So with that, I think we're turning it over to Courtney, right? You there, Courtney?
But I'm here, but I'm having issues with my screen. It just went to the CAPE banner. Let's see. Okay, there we go. Yeah, so can you hear me okay?
Yep.
Okay, great. Sorry about that. We wanted to take some time to acknowledge some community responses that we've seen related to this idea of mental health literacy, which is really a combination of being able to identify or recognize mental health issues, be able to refer someone for treatment or help them get access to that, and endorse treatment as an option for folks facing mental health issues, and also to decrease stigma. So part of mental health literacy is low or no stigma. So as part of the CAPE project, we developed a curriculum, and we were really focusing on people who work at land-grant institutions as part of extension. So this curriculum was meant to engage extension staff to improve mental health literacy, to equip them to enhance mental health literacy in the communities that they serve, and increase their capacity to begin work with and sustain work with local coalitions that are focused on community mental health challenges, whether they're ones that have existed for a while or emerging mental health concerns. So for this curriculum, it consisted of a series of webinars, and you can see the topics here. They included things like community action planning, needs assessments, how to make sense of all of the data that we could have access to, assessing how prepared a community is to engage in this work, and then engaging that community and building consensus about what action steps should be taken, creating strategic action plans, and then keeping going with that work. So that series of webinars was held in conjunction with a mental health first aid training for those extension staff, and we did have participants from across the country who were involved in this effort. Mental health first aid is an evidence-based curriculum, and its focus is on improving mental health literacy. Another community response that some of us are involved in with Michigan State University Extension, MSU Extension has recently formed a new community behavioral health team. And the goal of this team is really to improve behavioral health literacy or mental health literacy within Extension and within communities across the state, so that communities can be prepared and know how to respond to emerging mental health and substance use issues, even thinking about the opioid epidemic that many of us in our different states are working through. So part of this group will be offering mental health first aid trainings to Extension staff and community members across the state, and then to work on that decreasing stigma part, the team is hosting opioid film documentary screenings in several communities around the state, and afterwards having panel discussions with relevant community leaders such as mental health professionals, maybe faith leaders, folks in criminal justice, whether it's police or judges, and really opening up that conversation where people may have been afraid to have it before. So I think that's those are all of the community responses. Scott, is there anything you want to add?
No, I think we're ready for questions in the chat box, and Katie had an interesting comment. I think that's a good question or a good comment. That what would the response be if the employer or the respondent knew that there was active medical help going on, such as current therapy or medication? And I think that it might certainly reduce the amount of stigma associated with it if they knew the person was actively treating the condition. But we did not include that in our survey, but that certainly would be a good follow-up study. So feel free to put something in the chat box.
Well, this is Mark. Thanks a lot for presenting all of this information. There's a lot there, and you summarized it really well. In addition to the research papers that are coming out, we have summarized the results from the survey in a set of infographics. And so I put the link to those infographics in the chat section. If you have an interest in that, you can cut and paste that and keep it as a resource as well. I see Lisa is typing right now, so I think we've got another question coming.
Oh, great. So Lisa has shown the resilience movie. Has anybody else used that technique and want to comment on its effectiveness with audiences?
While we're waiting for any other comments or thoughts to come in, it'd be great to get your feedback. So we have this webinar summary evaluation here. That would be great if you could complete that as well.
Oh, that's a really good comment from Katie, is to add medical marijuana state as a control to see whether that affects the results. Yeah, that's a good thought. Thank you for that.
Okay, we have another comment coming in. Yeah, we will be posting this as a YouTube presentation with the recording, but if it's okay with all the authors, which I think it is, we can share the PowerPoint as well.
Yeah, I don't think we do it via email. We just put it on the website as a downloadable file.
Right. This is a good place to stop. Brent has had a comment there, so appreciate that, Brent. Scott and Courtney, do you have any last thoughts or comments you'd like to share before we sign off for today?
Well, I appreciate everyone's attention today, and again, we're open to feedback on the work because it is a work in progress. So if you have ideas, feel free to email me or Courtney, and we'll take your ideas into consideration.
Thanks for joining us today.
Okay, well, thanks everyone. Thanks Courtney and Scott, and we'll be posting the YouTube and the PowerPoint and sending that, at least a reference to those links out as well.